Okay, so welcome back. We're looking at chapter 20 today from your text, and we're looking at mechanical traction as our topic. So we're going to be reviewing indications, contraindications, parameters for the cervical spine and for the lumbar spine. And then we're also going to talk about some manual traction techniques as well as distraction techniques for the hip. So here are some of the objectives. Going to be looking at different types of pain, including chronic, referred pain. We'll discuss different various pain theories and their applications as they relate to traction. We're going to be looking at being able to really competently set up somebody on traction, which we're going to see more so in the lab for either the cervical or the lumbar spine. So here's just a few of the different types of traction units that you may see. And we have some of these in our lab setting. So you're going to be using these for your skill comps and in your lab activities. So the one over here on the very far left, you can see this is a cervical traction unit. And you have this nice little air pump right here. So you can set the degrees here. So you can have more cervical flexion or less cervical flexion. And that'll really help determine what segment of the cervical spine you're going to be treating. So at the lowest setting, you're going to be treating more of the upper cervical spine. So if the head is in more of a neutral position, you're going to be tractioning, C1, C2, C3, kind of that upper region. The more flexion you give, the more flexion you have whenever you're performing cervical traction, the lower the level on the cervical spine you're going to target. So like C5, C6, C7. These other units over here are home units that you can that your patients can buy essentially for lumbar traction. And we have something very similar to this in lab as well. So you're going to get some practice on this one. But you can see all of these nice little belts to kind of go around the ribs and the hips, just like you would see right here. And again, we have a nice air pump that you can use to really get that traction force, that distraction of those lumbar vertebrae. So you can see this patient's legs are in extension. So this is going to target more of the lower lumbar spine. If you put the legs up at about 90 degrees, you're going to target the higher end, kind of that L1, L2 area of the lumbar spine. So positioning does matter. We'll talk about that a little bit more as we progress through this lecture. Here's some just other different types of traction units. These ones are a little bit nicer than the ones that we have in our lab. But you can see this one over here. This is really common in the clinic. So it has a nice little armrest. It has the face plate for your patient. And then it also has these nice little stabilizing bars on the side, which is just going to provide a better stabilization, better traction in the long run. And you can see that these tables kind of move all over the place. So this would place your patient's hips in a little bit more flexion. So trying to target something like, again, maybe the middle or the upper lumbar spine. Okay, so you can do traction in prone, you can do it in supine, and you can see on this, in this image over here, this is a really fancy traction unit called a 3D traction unit. You're going to read a scenario or an article on this one, and you're going to review it. But they've done some studies that show that the effects of 3D traction incorporating more movements is more beneficial. And we'll talk about the mechanism of injury and why that's important, and how positioning can really, you can use positioning to your advantage to reduce herniations and get more joint separation. So this is a pretty nice unit here. You can obviously see she's in prone. Her hips are flexed a little bit. So we're not targeting that lower lumbar spine in this picture, but maybe the upper or kind of that middle lumbar spine area. And also you can see that the table is slightly rotated to her left side, and maybe a little bit, she's in a little bit of lateral flexion to the left side. So this is going to open up all those facet joints on this right side over here. So this is a pretty nice unit. I wish we had something like that in our labs. So let's just talk about some of the reasons that you could use mechanical traction. So let's look at these bullet points here. So we can use mechanical traction to distract the joint surfaces, and we'll talk about reasons why you'd want to do that here in just a little bit. We can use mechanical traction to help reduce protrusions of that nuclear discal material. We can use mechanical traction to help just stretch some of the soft tissue that may be limiting your patients with mobility and really kind of getting them into a lot of painful situations. We can use mechanical traction to help relax the muscles surrounding the joints, and we can also use it to just mobilize the joints in those hypomobile segments. So just some key anatomy to remember that's going to be important for understanding the purposes of mechanical traction, the effectiveness of mechanical traction. First thing that you're going to want to think about is this nucleus pulposus, right? So this is that gelatin-like material that sits inside the disc, and it moves around when you move into certain positions. So if you're moving into a lot of spinal flexion, most likely this nucleus pulposus is going to shift posteriorly. If you're moving into a lot of extension, it's going to shift anteriorly. Okay, as that nucleus pulposus shifts around, it's going to press into the annulus fibrosus. Okay, so this is that really top band of tissue that basically houses the nucleus pulposus. If we are in, let's just take spinal flexion for example. If we're in too much flexion for long periods of time, then this nucleus pulposus is going to push against the annulus fibrosus, and it's going to weaken that material. It's going to weaken that soft tissue that basically houses the nucleus pulposus. That's how we kind of get some of those disc protrusions. Okay. The other thing that we need to think about are the facet joints here. The zygapophyseal joints is another way that people like to describe those. So we'll talk about facet joints a little bit here, more so when we get in person in lecture, but it's going to be important to maybe understand some of the anatomy related to those facet joints. And then the other thing that we need to really consider is this intervertebral foramina. So if we have compression forces on our disc, okay, we have this other disc here. Remember that we have that little intervertebral foramina on that posterior side where the nerve root exits and leaves. If we have compression in that area, that space becomes smaller and smaller and smaller, and we call that stenosis. This is going to compress this spinal nerve root and give your patient radiating pain, weakness in whatever level this is here. So let's just say that's L4. And we'll talk about what muscles you might expect to see affected, what kind of sensory issues you may see affected by the level of this compression. So we need to really know those key anatomy. So let's talk about joint distraction now. So what is joint distraction? It is exactly what it sounds like. It's the separation of two articular surfaces perpendicular to the plane of that articulation. So we can use mechanical traction to reduce joint compression and widen that intervertebral foramina, like I just showed you on the previous slide. This also, if we get this joint distraction, may reduce pressure on the articular surfaces. So you can think of, let's just say like osteoarthritis in the knee, right? Reducing pressure on those surfaces where we have a lot of arthritis is going to reduce pain for our patients. We can also reduce the pressure on those intra-articular structures. So the nucleus pulposus, the disc itself, if we decrease the pressure on those structures, then we're going to see reduced pain and reduced symptoms. And this will also reduce the pressure on those spinal nerve roots as they exit that intervertebral foramina. So here's a nice little image just to give you a little visualization here. Let's just start on this left side over here. So central stenosis is a term that you'd want to familiarize yourself with. Same with lateral stenosis, but let's talk about central first. So whenever we're referring to central stenosis, this is the area that is becoming compressed. Okay, so we have this bone growth that pushes on the spinal cord itself. So it's not necessarily pushing on the nerve root, but it is on the spinal cord. So if we have something like central stenosis, we may see one particular type of symptom, okay? Then we see on the lateral stenosis side over here, the spinal cord looks good, that's not being compressed, but we have this bony overgrowth or this osteophyte formation, which is really compressing that spinal nerve root as it exits the column. Okay, so this one will give you other different types of symptoms as well. So we'll talk about that a little bit more in our actual lecture here. Then we look at the big image on the right here. So again, just to kind of familiarize yourself with the anatomy, these are some of the components that we're looking at. Here's that intervertebral foramen, right? You can see here's our nice little nerve root that exits out of that canal. If we have bony overgrowth here, right, it's going to compress. If we have bony overgrowth here, it's going to compress that nerve, and you'll probably see some weakness associated with that, sensory issues, and what we call radicular pain or radiating pain. Okay. You can also see some of the facet joints here, right in this area. So oftentimes people will have inflammation of this joint capsule, which will again create swelling in the area, compress against this nerve root, and it will also lead to decreased range of motion, stiffness, pain with movements. The other thing here that you can finally visualize and see is this intervertebral disc. So this outer portion here would be that annulus fibrosus. If we again move into, let's say, extension because it's easier to see on this slide, if the spinal cord is going this direction back, or the spinal column is going backwards, then this gelatin-like material that sits right inside this disc is going to move this direction. Okay, so it's going to press against that anterior longitudinal ligament. It's going to press against that annulus fibrosus and possibly cause a protrusion. So here's a nice little image that will kind of show you some of the effects of spinal traction. So we have lots of compression that's happening initially, and then we get that traction force, and you can see that intervertebral foramen size getting larger. We can see decreased pressure on the actual disc itself. So these are some of the reasons that we would use joint distraction, right? We're trying to decrease pressure on some of these structures here and here. We can also use mechanical traction to help reduce a disc issue. So some of the proposed mechanisms of getting this, of reducing this disc protrusion would be the clicking back of a disc fragment. Whenever we perform mechanical traction, we get this kind of negative pressure suction, which is caused by decreased intradiscal pressure. So we're taking the pressure off the disc, and that's going to basically draw that nucleus pulposus back into the center where it initially came from. So that is a really big part of, getting some of these effects from mechanical traction. And of course, we can also, by performing mechanical traction, create tension on that posterior longitudinal ligament or the anterior longitudinal ligament, whichever direction the protrusion is in, and that's also going to push that disc material back towards the center. So here's a nice little image that comes straight from your book talking about reducing that disc protrusion. So you can obviously see we have these forces moving in opposite directions. This is our traction force. That's going to decrease the pressure on this disc, and you can see this is your nucleus pulposus. It's pretty posterior at this moment. As soon as we reduce the pressure on that, well, now it's going to draw back in. And here's a nice little image on the right hand side. This is a belt that you can wear. We fitted a lot of people in our clinic for these types of belts. This is typically meant to help reduce the protrusions, gain a little bit of distance between those intervertebral foramen to decrease nerve root compression. But you can kind of see over here as we traction, again, we're creating less pressure on that disc, and it is going to reduce back to its normal position. Now this takes some time. It's not going to happen, within the first few seconds that you apply this traction force. it's going to take some time. So we need to definitely monitor our patients, let them know that, you shouldn't get an immediate relief of your pain. If you do, then you need to let me know because there may be something else more serious going on there. But this is another example of a wearable kind of distraction device, a belt essentially, that a lot of patients wear throughout the day. Now let's look at some x-ray images here. So again, looking at this disc herniation. Okay, so we have our spinal cord here. You can see this is in the cervical spine, obviously, and this nucleus pulposus is pushing into that spinal cord. Okay, probably getting a lot of radicular symptoms here, weakness in the upper extremities, what would be typical to see, sensory loss, those kind of things. And then here on the right-hand side, you can see this is a really large disc protrusion. We have our nice spinal canal here again. You can kind of tell where we're at in the lumbar spine here, L4, L5. Look at this big disc herniation pushing into that spinal cord. Do you think that's going to cause problems for your patient? Definitely. So we can use mechanical traction to help reduce this disc material back into the center by creating less pressure on the disc and kind of getting that suction to pull that nucleus pulposus back in. It is also very important to know that mechanical traction isn't going to be a long-term fix for your patients. It may help reduce their pain in the short term, but for something like a really large herniation, you want to limit the expectations on what mechanical traction can do for your patients. So let them know that this might help in the short term, but we need to figure out ways to make you functional, decrease your pain over time, and letting them know that mechanical traction isn't always going to be, the best option for them. We want to make them independent. We don't want to make them dependent on something like a passive modality. And here's just another few images that you can see here just to familiarize yourself. You can kind of see we're in that same area in the lumbar spine here. Again, same area of the lumbar spine. You can see all of these herniations and even a slippage of this disc moving forward, which we're going to talk about here in just a second. We can also use mechanical traction to help with muscle relaxation. So for anybody who's got tightness and they just can't seem to get rid of it, they're stiff in the mornings, those kind of things, mechanical traction is a really good option to help those muscles relax. So we can help facilitate relaxation of those paraspinal muscles, and basically this is going to be gating the pain transmission by stimulation of those mechanoreceptors. So we can use something like intermittent traction where we're pulling, there's an on cycle, releasing, not all the pressure, but some of the pressure on the off cycle. And this is again going to stimulate those mechanoreceptors and essentially gate the pain. So like the gate theory of pain control is something that we can utilize this for. Whenever we're setting somebody up on mechanical traction for muscle tightness, stiffness, we're really trying to stimulate those Golgi tendon organs. Okay, so if you remember what these Golgi tendon organs are really meant to do, right? They're meant to respond to tension in the muscle or tension in that musculotendinous unit, and that prolonged tension forces relaxation of muscles. So that's really what we're trying to do here. We're trying to stimulate these GTOs to inhibit alpha motor neuron firing. So again, just think of you holding a heavy weight, you're doing a biceps curl, and you're just isometrically holding it there. At a certain point in time, we are going to stimulate those GTOs with that prolonged tension, and they are going to relax or inhibit some of that alpha motor neuron firing. So we're thinking of the same kind of response here for mechanical traction. If somebody has muscle spasms in their back, we're going to try to break that pain, spasm, pain cycle. Okay, and we'll do that by stimulating these GTOs. We can also use mechanical traction for joint mobilization. There's plenty of techniques that you can learn manually whenever you're licensed and out working in the field. we're not going to spend a ton of time working on manual mobilization of the spine because that's something that is beyond entry level for a PTA and definitely a student PTA. But here's a nice technique visualized here in this image where you can kind of see here's your spinous process and your transverse processes off to the side. So this is what we call a unilateral posterior to anterior force. So you can see that the force is moving from the posterior side, the person's back, essentially towards the anterior portion of their spinal column, okay, or towards the front side of their body. So this has been studied quite a bit, and it's a really good technique to help manage pain, increase range of motion, but we're not going to really focus on that so much, at least the manual components. We're going to use mechanical traction to help mobilize those joints. So if somebody has hypomobility, right, they are limited with flexion, those facet joints aren't sliding as well as they should, then we can use something like mechanical traction to help mobilize the joints, get more range of motion, decrease pain all at the same time. So what are the indications for spinal traction? Well, you can see them all right here. So we talked about disc bulging or herniations. If we have a disc herniation or your patient has a disc herniation, we can use mechanical traction and we can position our patient in the best position to help reduce that bulge or that herniation. If we have spinal nerve root impingement, and again, this could be from osteophyte formation, decreased disc height, we can definitely use that to distract the joint and decrease pressure on that nerve root. Like we just talked about, joint hypomobility is another indication for spinal traction. We can also use it for subacute joint inflammation. So if there's not an acute injury, but kind of moving outside of that 7-day period, now they're in 2 weeks, 3 weeks, typically we would say that's about that subacute area, right? So if they have some subacute joint inflammation, we can use something like that intermittent traction to help reduce pressure on those spinal nerve roots, right? Remember, with inflammation, there's always swelling, those kind of things. So if there's inflammation in the area, it will definitely lead to nerve root compression and give you some of those hallmark signs and symptoms of nerve root compression. Muscle weakness, sensory loss or sensory dysfunction, those things. And again, we can use our mechanical traction to help reduce muscle spasms by stimulating those GTOs, creating inhibition of those alpha motor neurons. So let's just take a peek at this spinal disc bulge or herniation. So you can see in the image these different types of herniations. We don't have to worry about that right now necessarily. We can have this contained one, the protrusion, the extrusion, the sequestration. We're not going to worry too much about those at this moment. We're just going to focus on disc herniations in general, right? And how are we going to treat them? So kind of a basic level of knowledge on what's most appropriate. But again, this bulge decreases the size, the mechanical traction will help decrease the size of that herniated disc material and reduce compression on those nerve roots. You can kind of see that we have a common theme here, right? A lot of these injuries are going to relate to spinal nerve root compression. Something that I really want you to know, we're going to talk about this more in our class, in our lecture, but is this idea of flexion versus extension bias. Okay, so first of all, we have to think of how did the injury occur? So a lot of times people are going to injure themselves by bending forward to pick something up, picking up something heavy, using a shovel or a rake or something along those lines, and then trying to lift. And so from a flex posture, extending their spine, right, with a lot of load in their hands. And this is going to create a lot of pressure posteriorly. And that herniation is most likely going to happen in a posterior direction. And again, that's just because of the pressure gradient that's caused inside of that nucleus pulposus area. Okay, if your person is in flexion, right, and they injure themselves in a flexed posture, they're going to really benefit from extension type activities, positioning exercises. So we're trying to reduce this disc material. We're trying to get it back into the center. So we have to create a different pressure gradient. So we're going to move them into extension postures, positions, and that's going to help this disc material reduce back towards the center. Okay, we're trying to just play with the pressure gradient here. If somebody injures themselves in an extension posture, right, we're compressing the posterior side, that nucleus pulposus is going to move towards the anterior side, anterior posterior. Okay, so with extension positions, there's a lot of compression here, which is going to cause a lot of pressure, and that material is going to want to move forward. So for somebody who has an anterior disc herniation, they're going to really benefit from flexed postures. Again, we're trying to reduce this disc material back into the center here, so we need an opposing force. Okay, so you always have to ask the patient how they injured themselves. Okay, that'll give you a lot of detail on where to start your treatment. Everybody doesn't always follow this flexion versus extension bias 100%, but it gives you an area to start. Okay, so you always have to ask how the injury occurred, and then you need to place them in positions that will reduce their pain. Okay, so you can always follow up your question with how did you injure yourself with, are there any positions that make your pain better? Does your pain decrease in when you're lying down on your stomach? Does it feel better whenever you are in a flex posture, like if you put your legs up on the couch? That'll give you an idea of this flexion versus extension bias. So if you have questions about that, please let me know. Students tend to struggle with that at times. So come see me if you're really struggling with that concept. But this is also going to be a good, like understanding this flexion and extension bias will help you position your patient better for when you're actually performing mechanical traction. So let's look at some of these signs and symptoms, because I've been talking about it, of this spinal nerve root impingement, or also known as radiculopathy. Excuse me. So let's look at these signs and symptoms first. So obviously, this person is going to experience some pain. Typically, we're thinking of sharp, shooting, burning pain, right? Dysesthetic pain. If there's injury or damage to the actual nerve root itself, then you're probably going to see this dysesthetic burning-like pain. Okay? You can also see paresthesia, or tingling, numbness, or the sensation of pins and needles along the nerve root that is being compressed. So knowing your dermatomes, your myotomes is going to be really important for understanding, where in the cervical spine, where in the lumbar spine is this issue really occurring? What position do I need to get them in to target that spinal segment best? Because we are compressing those nerve roots, obviously, again, we're going to have some sensory dysfunction, but we're also going to see muscle weakness. So we may see decreased strength in muscles innervated by the nerve that's affected. Okay? So we'll talk about this in a little bit more detail as we get towards the end of this lecture. Because we are thinking of this nerve root impingement, right? That would be what we consider a lower motor neuron issue or a lesion. That's going to result in hyporeflexia or areflexia. So decreased reflexes or absence of reflexes. So if you see that in a certain area, like let's say you're just doing if you're testing for reflexes and they don't appear to be normal, then you need to go to the segment of the spine which is responsible for that reflex. And again, I mentioned this earlier, but dermatomal sensory changes is something that you might see as well. So knowing your dermatomes is going to be important. The main causes of these signs and symptoms due to nerve root impingement, again, would include disc herniation, osteophyte formation or encroachment, and disc degeneration. And then we also have this spondylolisthesis, which we haven't talked about a lot, but I do want to show you a slide that kind of has all three of those on there. So obviously on this far left side image, we have that herniation, the disc, impinging upon that spinal nerve root. You can see here we have disc degeneration. So we have disc height loss, which is going to further compress these spinal nerve roots in that intervertebral foramen. You can see here that we have bone spurs that's doing somewhat of the same thing, right? Decreasing the space for that nerve root to exit. And then the other one that we're going to discuss here is this is your spondylolisthesis. Okay, so this is where we have one disc, this L5 disc, that is sliding forward. It's slipping on the vertebra that's below it. And you can see it in this X-ray image over here. Okay, so there's been a lot of discussion on whether or not somebody who has a spondylolisthesis is appropriate for mechanical traction. But in my eyes, you know, if it's bad enough, like this one here on the right side, this is somebody that I would be really hesitant to use spinal traction with, because technically this is instability of the spine. And we're going to see when we look at our contraindications, any type of cervical, lumbar instability is a contraindication. So there are some people who, there's different grades to the spondylolisthesis. So there are certain grades that people will still use traction with, like if it's less severe, they may perform traction to just decrease this compression of the spinal nerve root. But in my eyes, I would think, you know, that's a little risky to me. It's already hypermobile, and we're going to distract the joint, possibly causing more instability or hypermobility. So when you're out in clinic and you see this diagnosis of spondylolisthesis, you may want to ask your supervising PT, what grade is it considered to be a stable spondylolisthesis, or is it unstable? And that will really guide you in your direction for, you know, performing mechanical traction or not. But I've had some experiences in the clinical setting where, you know, the supervising PT wanted them to perform mechanical traction. They had something similar to this image on the right here, and they did not respond very well to it. So again, personal experience plus just knowing that this is spinal instability, you know, it didn't seem appropriate to me to do it. So I just had my supervising PT do it because I don't want to be responsible for that. I know I'm following the direction and the plan of care that the PT set out, but if you don't feel comfortable doing something, by no means do you have to perform mechanical traction. So just always think about that whenever you're out in clinic. So kind of the opposite, if we have somebody with joint hypomobility, then mechanical traction is great, right? There's not enough movement in those spinal segments, so we want to increase mobility to increase movement in functional planes and patterns. The hard thing with using something like a joint mobilization in the lumbar spine using mechanical traction is that it's really hard to localize on a specific spinal segment. So if somebody has decreased movement at L3, it's kind of a weird 3, but you get it, and you perform spinal traction, you're not just going to mobilize that segment, you're also going to mobilize L4, L5, higher up into the lumbar spine. So it's very difficult to just mobilize that one segment. Maybe this is where manual joint mobilizations would be better, but still, even then, you just have to consider, you know, what's happening above and below that segment, because there is possibility that there is hypermobility in the lower segments and hypomobility in the upper segments. So you just really want to be cautious with that, which is again why we're not going to do a lot of mobilizations or manual techniques to mobilize that lumbar spine or the cervical spine. Okay, and like I just said, hypomobility and hypermobility can exist together. So typically this is position dependent. Okay. There are some good techniques that we can use if we're going to perform manual mobilization or distraction. So this is something that you will learn, not so much just the posterior to anterior mobilizations. We're not going to really talk about those much, but we are going to perform this long axis and short axis distraction. So long axis would go through the hip, essentially through the knee, sometimes through the ankle, and you have to really kind of rule out if there's any hypermobility in those joints or if it's appropriate to mobilize through those joints. But we're also going to do something like a short axis distraction, which we can kind of take the knee out. We're still going to get through the hip some because that's just part of the short axis distraction. But it's really good, this long axis and short axis distraction, not only for the lumbar spine, but for the hip joint itself. So if somebody has osteoarthritis of the hip, these will be really good techniques. We can use a mobilization belt. We can use just our hand placement. So we looked at a few of those already in our previous lab, but we're going to kind of continue to build on those skills. And again, whenever we were talking about subacute joint inflammation, just remember that inflammation causes swelling, causes pressure on those peripheral joints, the spinal, nerve roots, those kind of things. So using mechanical traction can help reduce that pressure on those inflamed areas and really improve somebody's pain. Okay, the other thing that we need to kind of think about with mechanical traction or any type of mobilization essentially is that we are increasing joint nutrition. So we're getting normal fluid exchange in the joints, which is a good thing, right? We're trying to get rid of those chemical mediators that are causing inflammation, and we want new nutrients, oxygen, new blood flow to the area to help improve the joint nutrition. So again, we can use small oscillating motions to kind of gate the pain on those mechanoreceptors. And the only time that you're really going to see static traction being used, where you're not setting an on cycle and an off cycle, is if somebody is there for the very first time and they've never received traction before. That's the one time, at least for our purposes, that we're going to use static traction. And we'll look at all the parameters here in just a few minutes. Again, now looking back at muscle spasms, we're trying to inhibit hypertonic muscles. So we can do this by using static prolonged stretching, which is typically what we do with normal range of motion stretching, those kind of things anyways, or intermittent traction to again kind of break that pain spasm pain cycle. So again, trying to inhibit the muscle, we're stimulating those GTOs to decrease that alpha motor neuron firing. All right, make sure you star this slide, contraindications here and precautions. There's going to be some from this section that I do want you to know and that you'll be tested on. You're definitely going to have to know these ones no matter what. Okay, so let's look at these contraindications. So the first one here is discussing when motion is contraindicated. So oftentimes after any type of spinal surgery, there's going to be, very strict precautions for movements and things like that. So one example would be a lumbar fusion, right? We're going to limit bending, twisting, lifting, or you can think of it as BLT. Okay? If there's acute injury to the disc itself, then we may also say that motion is contraindicated in a forward flex posture. So you're just going to ask your patient if their physician has ever told them not to move in certain ways. If yes, then spinal traction is out for the time being. With something like lumbar fusion, we're going to just stay away from that, right? They've stabilized part of the spine, but typically the adverse effect of something like spinal fusion is that the segments above and below the area of stabilization become hypermobile. And again, if there is any hypermobility, then we're not going to traction that area. If there is acute injury or inflammation present, then we're not going to perform spinal traction. We can start to do it in that subacute phase. Hypermobility or instability, so you're thinking of that spondylolisthesis, really cautious about something like a spinal fusion, even if you're just doing manual traction or a long axis distraction, again, you just want to think of the segments above and below the spine. What's really happening there? Is there instability present? If you even think there is, then we are going to say no go to spinal traction. This next one here is peripheralization of symptoms. So what does that really mean? If we're thinking the pain is peripheralizing or not centralizing. Okay, so peripheralization of symptoms is something that you are going to assess once the traction is being administered. So if you put somebody on spinal traction and you're hanging out with them for the first few minutes and their pain is getting worse, as in it is traveling further down their leg or further down their arms, then that's a bad sign. That means we're causing compression somewhere else, which will give you more of those symptoms. So we want the pain to centralize. We want it to get closer to the area where the lesion is at. So let's say somebody is on traction, they reported pain in their anterior thigh, down into their lower leg. You put them on traction and they're like, well, the pain is not so much in my leg anymore, but it's really close to my hip and my low back area. That's a good sign. If somebody has just hip pain, okay, and you put them on spinal traction and they're saying, well, now I'm feeling that into my toes, and that's a bad sign. That means the pain is peripheralizing, it's not centralizing. So we have to really monitor that during our session. And if somebody has uncontrolled hypertension, we are going to avoid spinal traction here. Okay. Some of the other precautions that I really kind of want you to know would be really this one here and this one on the bottom. So I've seen this precaution mentioned on a lot of the NPTE practice test quizzes, and it says what is a precaution for cervical spinal traction, and TMJ disorders or dentures is kind of one of the more common ones that I've seen. But you really need to know this one that I circled above. So when severe pain fully resolves with traction, that's a bad thing too. So if they say, I don't feel anything anymore, that should give you an indication that you are fully compressing that nerve and they're not getting anything distally anymore. Bad sign, okay? So they shouldn't feel a complete relief of their pain. They should still maybe have some, and it should get better. But if it fully goes away, that means we're really compressing something to the point where they're not getting anything distally, right? There's no transmission distally after that. So those are the two of the precautions that I really want you to know. So here is an instance where you may see something like peripheralization of symptoms, or where you may see that complete loss of their pain. So let's just look at the far left side first. This is a lateral disc protrusion. This is a little bit easier to treat because you can see as soon as you perform that traction, like it's compressed over here, as soon as you provide the traction force, it's creating space here for this nerve root to finally breathe. Okay, that would be a good thing. Whenever you have this kind of medial protrusion, you can see that once this traction force is applied, now it's actually causing more compression here. So again, this could lead to your peripheralization of symptoms, or it could lead to that complete loss of pain, which are both bad. So medial versus lateral protrusion would be something that you may see. Okay, so let's move on to some of our special tests and screens before we get into lumbar and cervical mechanical traction. So I really want you to review these videos, and remember I told you that I really want you to know this vertebral artery test. So we're testing blood flow to the hindbrain, okay? And just remember that we're going to put our patient into extension from supine and a little bit of that rotation. And we're testing the opposite side for blood flow. So we're looking at their eyes to make sure that they don't have any nystagmus, that they don't have any blurring of their vision, and that they can continue to speak to us. So we're going to have them count out loud right to 20. So this is the one I really want you to know for our cervical screenings. But please go back and watch some of these other ones. This is a compression test. This is an instability test. And you'd probably follow up something like this Sperling's test with a distraction test to ensure that you have two tests saying yes, compression is causing some of their symptoms. You have to know all of these ones for the lumbar screening test. So the straight leg raise test, the slump test, and the prone instability test. Again, remember that these first two, we're trying to reproduce the patient's pain. We're trying to find that concordant sign. So we are basically tensioning that neural tissue. We are putting them in a position that possibly exacerbates the herniation. So we would want to see the same signs and symptoms here, which would be a positive test. Remember that for the straight leg raise test, if they just feel tightness in their hamstring, that's not positive. We're looking for that dysesthetic, shooting, sharp pain that they're typically feeling. Slump test, we're kind of looking at the same thing, but we can tension the neural tissue even more by dorsiflexing the foot passively or pushing them into more of cervical flexion. The prone instability test, remember they're prone and you're palpating, you're doing that posterior to anterior force. They're going to lift their legs up off the table. If they have pain before they do that lift, and then it goes away once they stabilize with hip extension, then that'd be your positive test. What I really want you to know is the position for these. Okay, we'll talk about these again in semester 3, but you need to be able to identify which one is happening based on an image, and then we'll continue to add to that as we get further into this program. Here are some of the adverse effects of spinal traction. So excessive force may increase symptoms, kind of like what we just talked about. If somebody's in a lot of pain or they have that medial disc protrusion, that excessive force may make their symptoms worse. Okay? As soon as people get off of spinal traction, you're going to have this rebounding. Okay? So we just distracted their spine. We took a lot of pressure off some of those structures. As soon as all of that tension is released, it's not going to be a permanent change that we get with that distraction. It's going to be very short-lived. So as soon as that compression happens again or we get increased pressure again, that could lead to increased pain initially right after that mechanical traction is applied. So we're going to start really slow. We're going to increase slowly. We're going to gauge their tolerance to this modality, which is why we'll see for the initial sessions, there's going to be a limit on the poundage essentially, or the force that we're producing. So if they don't do well with that initial session, then maybe mechanical traction isn't a good thing for them. If they do really well with it, then sure, we can set them up on the parameters that are appropriate for their diagnosis, but still we need to really pay attention to this kind of rebounding pain. And there just may be lumbar radicular discomfort after cervical traction. So their pain may increase because of this rebounding just after applying traction. So we're going to kind of skip past this part here. We've talked about different types, various types of spinal traction. We've seen at least the traction belt, the distraction belt. There's going to be different positions that we're going to talk about in our actual lab. There's different devices, there's continuous versus intermittent, and we'll talk about those in here in just a second. But let's look at a few images really quick. So this is more like the traction unit that we have in our lab. So if we're looking at this patient, they're supine, they have the belts around their hips and around their rib cage, and their legs are at about 45, a little bit higher than that. So remember that the higher the legs are here, the higher up in the lumbar spine we're really targeting. Okay, So we're thinking this is probably like L3, L2, L1 area. If the legs were completely straight, then we're thinking that's lower lumbar spine. That's going to be kind of your L5, L4, maybe S1 area. So you can definitely use this position in supine with the legs elevated. That's perfectly fine, but you would be targeting some of the upper lumbar spine. For this one here on the right-hand side, this person is in prone. So if you were, remember we talked about the flexion and the extension bias earlier. So if this person injured themselves by bending forward and lifting something heavy, then they're more than likely going to fall into what we call an extension bias, whereas that just means they like the extension position better because it's reducing pressure on those different structures that we mentioned earlier. So the nucleus pulposus would be traveling this direction here, technically. So it's reducing more anterior, okay? But this would be for a posterior herniation. And the legs are completely straight, so we're thinking this is really low lumbar spine, L5S1. We have both of these belts in our lab, so this one is sometimes a little easier to use, but these ones are really good too. Just depends on your preference. This one is all on the right hand side. Just space what that is, Velcro. And these ones over here have actual belt straps that you can tighten down. I tend to like these ones better over here. It gives you a better hold, and you can actually place these on the patient's skin to reduce sliding from their clothing. The ones on the right, again, very effective, but a little bit harder to really prevent slipping of those belts. Okay, let's get into the parameters. You're going to need to star this slide and all the other ones that have the parameters. So this one's specific for lumbar traction. So when we have the initial phase or that subacute injury, there's a force limit here. So you can see our force we're going to set anywhere between 29 and 44 pounds. Our hold and relax time is going to be static. Okay? And our total traction time, 5 to 10 minutes. Then let's say this person who really needs joint distraction does very well with this initial phase, this initial application of mechanical traction. Then we can get into our next session and really use something like joint distraction if they have stenosis. Okay? So our force for joint distraction, where we're actually trying to create that kind of negative pressure inside the joint, we need a pretty high amount of force. So we're going to take 50% of somebody's body weight. So if somebody is 200 pounds, right, times 0.5, we're going to use 100 pounds of force to distract that lumbar spine. For our hold relax time, it's a 1-to-1 cycle, but we're going to use just 15 seconds on, 15 seconds off. And you can see our total traction time, 20 to 30 minutes. So this is the highest force that you'll see for joint distraction. So still looking at lumbar spine here. Now if we're trying to decrease a muscle spasm, you can see we're going to reduce that force from 50% down to 25%. The relax time, hold relax time, still a 1-to-1 cycle, but we want more on-off cycle. We want more cycles essentially to help decrease that pain, spasm, pain cycle. So we're going to set it at 5 to 5, 5 seconds on, 5 seconds off. Still 20 to 30 minutes for our traction time. For disc issues or a soft tissue stretch, we're still going to use a pull force of 25% of somebody's body weight. The hold relax time is going to be longer, right? 60 seconds on, 20 seconds off. And it's really important to note why we're doing this, okay? So if we have a disc issue or a herniation, remember that material that sits inside the disc is like a gel material, okay? It's not watery. It's not going to move really quickly. So if we're trying to reduce a herniation out to this posterior side here, we want a significant amount of time with that traction force to help reduce this issue. Okay, so we need a long time, 60 seconds, on to help this material move more centrally towards the center of that disc. And same thing if we're thinking of soft tissue stretch here, right? We're trying to stimulate those GTOs. And the inhibition really comes from prolonged tension on those GTOs. So we need a long on cycle to help inhibit that alpha motor neuron firing, trying to decrease any tension in the muscle. So we need a long on cycle. So still 20 to 30 minutes total treatment time here, but not too bad if you think about, these parameters. There's our 29 to 44 pounds. We have 50% for joint distraction, then 25 and 25% for these other two issues. So then the other thing to think about is the on-off cycle. And you can always remember that we need a longer on-off cycle for any disc issue or soft tissue because of this component here and for stimulation of the GTOs. And this is what our cervical traction unit looks like. So very similar to this one here. Let's look at our parameters for cervical traction. So for our initial or an acute phase, or really subacute phase, we're looking at about 7 to 9 pounds of force, and that's it. So it's not going to feel like much for your patient. Sometimes just the position that you put them in will actually be more beneficial than just providing 7 to 9 pounds. It's very minimal. But still, in this initial phase or this acute phase, we're going to be really cautious, and then we're going to monitor their response. For all of the initial or subacute phases, we're going to perform a static traction. And again, it's only 5 to 10 minutes here. For joint distraction, okay, our force is a little bit more. So your book says 7% of the body weight. You can really go anywhere from 20 to 29 pounds. So I've seen on the NPTE practice test, they've used both of these. So they've used the percentage of body weight. Sometimes 7% of the body weight does not get anywhere close to this 20 to 29 pounds, but you really don't want to go more than this 20 to 29 pounds. Okay, so you can use either or. And I would say this is probably more realistic on what you would do in real life, but you still need to know 7% of the body weight. Joint distraction, it's the same as the lumbar spine. It's a 1-to-1 ratio, but 15 seconds on, 15 seconds off, and 20 to 30 minutes. And we're starting to see some more patterns develop here, which is nice. So in the cervical spine, trying to decrease muscle spasm, a force of 11 to 15 pounds would be appropriate. You can still see we're trying to break that pain spasm pain cycle 1-to-1 ratio, but 5 to 5, that's the same for the lumbar spine, and so is the total treatment time. For our disc issues or a stretch of soft tissue, again, same force, 11 to 15 pounds, which is similar to what you'd see in the lumbar spine, 25% of the body weight. Now we're not using body weight so much, we're just using a poundage number. And again, for the hold relax time for a disc issue or a soft tissue stretch, we're still using 60 on, 20 off, okay? So find some patterns in those parameters to help you really learn those. There are some different advantages to mechanical traction versus manual traction. I really wouldn't worry about these too much. But I do want to talk to you now, this kind of last section here talks about hip traction and distraction with a resistance band. So there's a lot of different setups that you can use, but you can see here a really thick, strong TheraBand, or they call this like a pull-up assist band. You can utilize this and educate your patients on the use of something like this at home to maybe help with their hip pain and to get long axis distraction all the way up to the lumbar spine. They also have these hip track devices that's going to help with this hip distraction. So you can set it at different angles here. You can move your leg into abduction, external rotation, and then you just pump it up like a bicycle pump. And this is the part that I really want you to know about hip traction, okay? Specifically, the degrees of hip flexion, abduction, and hip rotation for pain relief and for when you're trying to increase range of motion. So if we are trying to just improve pain, decrease pain, we want to put them in, essentially an open pack position of the hip. So we're going to flex that hip to 20 or 30 degrees. We're going to put them in a little bit of abduction, 15 to 30 degrees, and then we're going to maximally externally rotate that femur. We're going to do almost the exact opposite, increasing range of motion. So instead of putting them in flexion, we're going to put them into extension as tolerated, abduction as tolerated as well, and then instead of external rotation, we are going to internally rotate that hip. So you need to know those positions and the goal for those positions. Okay. And then here are some other just kind of home techniques that you could use, or positional techniques that will be really beneficial for your patients. So you can see here, performing a little bit of distraction. It'd be better if the feet were dangling here so that it's getting a pull this direction and a pull this direction. But nonetheless, that'll work. If we are trying to gap this left side, we would like to place a pillow underneath the right side here, basically putting this spine into a little bit of lateral flexion towards the right, and this will open up those intervertebral foramen space on this side here. Inversion traction is something that some of your patients will probably have. We looked at the uncontrolled hypertension as being a contraindication. Definitely for this person here, or this machine, that person can't get on there. Or if they have intracranial pressure, this is a really bad technique or device for them to use. So just be really cautious. If they have one at home, make sure you educate them on some of those different things. I showed you this technique in lab, so just using manual traction. You just have to be really cautious with this position because we are basically pulling the tibia into an anterior position, and this could be very similar to what we see as an anterior drawer test. So if they have knee instability, probably not the best technique to use. And then there are different techniques for manual cervical traction. This is something that I would probably star this slide here, talking about myotomes. So myotomes relating to the actual motor function that these nerve roots affect. Okay? So I'm going to keep it fairly easy for you and say that I want you to know the lumbar spine. Okay? So L5 to L1 here. So L1, L2, if we have compression there of the nerve root itself, you're probably going to see weakness with hip flexion activities. If it's at the L3 area, they may be weak in the quadriceps or knee extension activities. L4, L5, you may see some foot drop happening. Okay, they won't be able to dorsiflex their foot. And L5, great toe extension. So those are the ones that I really want you to know. You're going to learn more about these with the Asia scale this semester. And I think that is a really good tool to study dermatomes and myotomes from. But these are the ones that I want you to know for my class. What does the L1, L2 nerve root myotome look like? It looks like hip flexion. What does the L3 nerve root myotome look like? It looks like knee extension, and so on and so on. So one of my questions that I might ask is, someone presents with decreased quadriceps strength and they're unable to perform knee extension against resistance. They may have a herniated disc, and I'll say which area of the lumbar spine is most likely affected. And then you're going to say, I know that one. It's L3. Okay, so that's an example of a question I might ask. And of course, we always finish off with documentation and billing, just the codes that are associated with it. So here's your code for mechanical traction. Here's your code for manual traction, basically just manual therapy. And we'll talk about those a little bit more.